provides continuing education for our Stephen ministers to help them with their caring skills, to stay sharp and to stay engaged. And one of the topics that we talked about having for continuing education for our Stephen ministers was hospice, just to become more familiar with that, to help them with their ministry, their caring ministry, and know about hospice and what a hospice can offer. So we started talking about this topic and realized that it's really good information, not just for our Stephen ministers, but for the whole congregation. And that's part of the reason that Stephen Ministry is sponsoring this today. Lynn Finland is the Stephen Ministry training coordinator, and unfortunately she couldn't be here today. She's under the weather with a chest cold. So, but she's the one who made the arrangements with Via Health Partners, who is the largest hospice and palliative care provider in the Charlotte area. She made those arrangements and she made the cookies. So when you see her in next week, whenever it is, after she recovers, please thank her for both of those. She made these arrangements with Amy Weatherup from Via Health Partners. She is a strategic account manager and has worked in the healthcare industry for 33 years, including long-term care, senior independent living, hospice, and home care. She has a postgraduate degree in thanatology. I had to look it up. It's the scientific study of death and the losses brought about as a result. She is, did I get that right?
Yeah.
She is a certified dementia dialogue educator and a certified death doula. Part of her duties with Via Health Partners is to provide education to the community, including courses in dementia, communication with dementia patients, difficult behaviors of dementia patients, team building, morphine myths, personality styles, end-of-life symptomology, and psychosocial needs at end of life. She has taught sociology and social justice at the college level. And in her free time, Amy enjoys cycling, hiking, and photography. She has 2 college-age sons and a COVID puppy. Amy, welcome to Carlos.
Thank you. Thank you. Although the first thing I was thinking when I was sitting over there is I know how you feel now because nobody wanted to sit in the front.
Just Presbyterian.
Good morning, and thank you for inviting me. Happy Mother's Day to all our mothers. I will tell you that when I realized this was Mother's Day, I sent a message and said, "You realize it's Mother's Day, right?" And they said yes, and asked if that was a problem for me, and I said, "Nope, as expected, my children are still asleep because they're college-age students, so they won't even be awake before I get back home." So thank you for having me. Again, my name is Amy, and I have worked for 33 years, it makes me feel so old, always associated with healthcare. I'm a social worker by trade, but have always worked in healthcare at some level, and probably from the time I was 13, I knew that this is what I wanted to do. I volunteered at a nursing home and fell in love with older people, and it takes all kinds to make the world go round, and I'm glad because I would never want to work with children. I love my children, but I would not want to work with children. We do have a children's program that I'll talk about a little bit, but I am not part of that. However, I'm here today to talk to you a little bit about hospice and palliative care, which are 2 totally separate entities, so I need to talk about that a little bit louder. Sorry. So how many of you have had somebody under hospice care in your family or friends? Okay, so a lot of people. First thing I'll say is I've always approached at events and somebody will say, "Oh, you took care of my mother in Nebraska." And I'll say, "Nope, not us." Hospices are all individual. I think we did a disservice when we first started naming hospices, and we did things like name them Hospice and Palliative Care of Charlotte, which is what we were for 44 years. And there's a hospice of Union County, and there's a hospice of Iredell County. So people assume that it's a government program. It is not. Every hospice company is owned and operated individually. We are the largest independent hospice on the East Coast, so we are large, which is why we changed our name. In the back, there are some maps so you can see based on where you have people that you might talk to, but we cover all the way from Hickory all the way down to Greenville, South Carolina. We just opened an office in Columbia, South Carolina, so we are expanding all the time. Not because we are operating in new areas, but because we are coming together with smaller hospices, because as the medical industry changes, small independent hospices are not able to survive on their own. So we have taken over other organizations to grow. In the state of North Carolina, you have to have what's called a certificate of need to open a hospice, and that, or get licensed for hospice, and that is done by the House. So the government decides when there's a need for another thing. It's the same with nursing homes in North Carolina, or mental health hospitals in North Carolina. The government decides when there's a need for something. So we are one of probably 5 that serve the greater Mecklenburg area. Both Atrium and Novant have their own hospice systems. There is an organization called Gentiva, which some of you may have known as a home care company. Their home care company is no longer called Gentiva, but their hospice is called Gentiva. And also there is another smaller for-profit in the area whose name is changing all the time, so I won't tell you their name because it will be different by the time somebody needs it. But on that note, there's something to be said. There's for-profit and not-for-profit hospices. And when you are looking for a hospice for a family member or a loved one, or to talk to somebody about, it's important that they know that. Whenever I speak to somebody who's from out of state, I always tell them to look for the not-for-profit hospice in their area, because as we know, if it is for-profit, then the choices that they're making and how they spend their money will be different than a not-for-profit organization. So, hospice versus palliative. It looks like almost everybody has been affected by hospice service here. So you know the basics most likely, which is hospice is end-of-life care for people who 2 doctors decide have 6 or less months to live, based on their best guess if the disease progresses the way they think it will, which is a really long way to say that there's not anything aggressive that can be done for someone anymore, and if the disease process goes as expected, that person has 6 months or less to live. But we were just sitting here talking about Jimmy Carter, who has been on hospice for a year, and it just needs people to be able to show a decline in somebody's well-being. And I mentioned that prior to Rosalind's funeral, he was still up and walking around, but if you saw the funeral, you saw that he was in a wheelchair because he's no longer able to walk. So that's showing a decline as his disease process goes. The other thing I say is, we don't call it practicing accounting, but we call it practicing medicine, because there are a lot of things that determine how long somebody lives with a terminal disease, and doctors aren't always able to put in all those extra things. I will tell you, people live for events, and perhaps some of you who have had a hospice patient have seen this. It's somebody who has something that's coming up in their life, and they are determined to make it to that. They're determined to make it to a wedding, or the birth of a child, or the graduation. We had someone in Charlotte who was a relatively young patient. She was in her 50s. She had advanced cancer, and her daughter was going to Arizona State, I'm not from North Carolina, to ASU, the other ASU. And she was going to be the first person to graduate from college in her family. And her mother was determined to make it to her daughter's graduation. And our nurses knew that she wasn't going to make it until May, until graduation. So our social worker reached out to the school, and they sent the chancellor and the dean of her school in full regalia, and they came to her home, and her daughter graduated in the living room in the middle of the semester, and the mother lived 2 days. So people live for things, and we are there to walk with them through the journey, meet them where they are, and help them. One of the questions we always get, who pays for hospice? The healthcare system is changing all the time. Anybody who's dealt with the healthcare system knows that it's pretty fractured and hard to manage. The beauty of hospice is that Medicare pays 100% of hospice services. That means they pay for all the medicine, all the equipment, all of the nursing visits, all the social work visits, all the home health aid visits, follow up with the doctors. If somebody needs palliative radiation for comfort, all of that is covered 100% by Medicare. And anyone who is still on traditional healthcare or insurance knows that all of our insurance companies follow Medicare standards. That's how they determine what they're going to offer. The only caveat in that is if you are someone who's eligible for Medicare and you've chose an advanced Medicare option, when you choose to go on the hospice benefit, you switch back to traditional Medicare, and that's because those insurance companies weren't willing to pay the cost of hospice care, and so Medicare negotiated with them to take people back who switch on to hospice. We thought that was changing, and they started a program this year where they were monitoring to see how it would be with insurance companies having to pay for the hospice benefit, and it completely failed, and now that's off the table. So going forward, it's still going to be switching back to traditional Medicare. And people have asked if I switch, then I go off hospice, because some people do graduate. What happens with my Advantage program? And honestly, you have to wait until the next open enrollment before you are eligible to get back on to an advanced program. My take as somebody who's worked as a social worker and in the healthcare system is somebody who's eligible for hospice, even on the short term, I would never put them back on an advanced program, because what you're doing with one of those Advantage programs is you're putting a moneymaker between you and your guaranteed benefit. And this is off topic, but for instance, if you go to the hospital and go to a skilled nursing facility for rehab, that insurance company will determine when you have to go home versus the therapist deciding when you need to go home, whereas with Medicare, the therapist will decide. So it's very beneficial for people who are still out and active, but over the age of 65 and like the glasses and like the hearing aid and like all the things that they offer, but once someone's health declines, it's best to be on a more traditional Medicare plan. Caveat. Okay, so in the back, I've left some paperwork, and I know that I had sent a lot of electronic handouts, so they will be available to you if you don't take the hard copy today. But one of the things that we put out, which I think is the best piece of paper to hand to somebody, is something called Hospice Dispelling the Myths. Because there are a lot of myths about hospice that go back years. You know, hospice became big in the late 70s and early 80s in America, but was in place in Europe for years before that. And when it was brought to America, most places had a place called hospice, a hospice house that people went to. And people would live there for, well, when I worked in Union County at the hospice houses out there, we had one lady who lived there 3 years. It was just different. It was a different experience. It was actually completely different before Medicare became so involved and started making regulations that hospice companies now have to follow. Some of the myths that people hear are, well, you guys probably know them. They put my mother on morphine and she died the next day. I think that's the biggest one. We struggle with that even with caregivers in facilities who are required to give hospice patients morphine on a regular basis, particularly the girls who are med techs who are giving medications, so they aren't nurses, but they're giving medications at assisted livings. They can be very uncomfortable with this because everybody has the story of somebody who took morphine and passed away, or the picture in their mind of the person laying in the hospital pressing the button over and over, not understanding that that button is only giving them medication when it's prescribed. So no matter how many times you push it in 4 hours, you only get it one time. But there is actually proof that people on morphine live 5 days longer than people who are not on morphine, because being able to be comfortable at the end of life helps that person transition to death in a much calmer way. We use morphine for 2 things: pain, which is what most of us think of when we think of morphine, and 2, for what many of you may have seen or heard about, and that's the very shallow breathing at the end of life, where you hear somebody kind of gasping for air. And morphine helps that, and that's why people think that you give somebody morphine, their breathing slows down, and they die. They believe that you can overdose somebody on that. Not true. The beauty of morphine is that there is no top level of morphine that you can give. You can give it very high levels, very close together, sometimes 15 minutes apart to keep somebody comfortable. And what morphine actually does, our pharmacist gave a talk I was only working about 3 days for this company when I heard this talk, and I thought, that's such a brilliant way to explain it because anybody not in the medical field can understand. He said, when your knee hurts and you take an aspirin, the aspirin doesn't go to your knee. It goes to the pain receptor in your brain and turns it off. Same with morphine. When you give somebody morphine, the morphine goes to the part of the brain that is the alarm that we have in our brain. Our brain has an alarm that tells us that we have too much CO2 in our lungs. So when you see that person breathing shallow, it's not because they can't breathe in, it's because they're too weak to expel CO2, and the brain starts to panic. It's the reason people breathe underwater when they're drowning, because we know we need to get the CO2 out and get oxygen in. So all the morphine does is turn off that alarm and allow that person to breathe slower, just as shallow because there's CO2 in their lungs, but just breathe slower without so much panic. Morphine is not a killer. The people that we hear about in the world and all the opioid stuff that's going on is used and utilized in a different way than we use it. All of our morphine is given through liquid. We don't give pills. We don't give it intravenously. It's all done underneath the tongue, absorbed through the body very easily. And the beauty of that is you can give it to somebody who is no longer swallowing or is not conscious, and so it can help keep people comfortable. However, that being said, there are families who choose not to have any drugs because our job is simply to walk with that person through the end of their life the way they choose to live it. As Christians, we don't stand on a place culturally that we would say there needs to be pain at the end of life, but there are some religions that they believe that pain at the end of life is part of the transition that's going to get them to their Holy Land. And so this is a choice that they make, and we respect it as a hospice company. Okay, that's one. Has everybody heard that morphine myth before? That somebody, yes, okay. Second one is it means the doctor has given up on you. I will tell you, doctors have a very hard time making a referral to hospice. Doctors went into medicine to cure people, and turning someone over to hospice means that at some level they have failed to cure someone. And it's a very difficult decision for them and a difficult conversation for a lot of them to have. They don't spend a lot of time in it in medical school, unfortunately. Having the conversation with people and how to have it in a way that presents it as just the next option. We plan for everything. We plan birthday parties. This event has been planned for 3 months. I started meeting with this team to talk about it. You planned Mother's Day today and what you were going to do, and some of you didn't, and you're going to go buy flowers on the way home and all that, but we plan everything, but we don't often plan well for our own death. And one of the things hospice can do is help people with the organization, help them plan for what their death looks like, what they want it to look like, how they want it to happen. Most people aren't afraid of death. They're afraid of the dying process. They're afraid of losing autonomy and losing control and losing all those pieces that make us who we are. And a hospice team can help the family and the patient make plans that everyone's comfortable with. Side note, also what a death doula does, which is the other certification he said that I have, much like a birth doula, is somebody who walks with a family and a person through the process of the end of their life. And it's a big role of helping people feel that control. All the way down to, I want to be in my bed, I want my bed facing, my feet facing the window, I want my cat in there, I want everyone to take off their shoes when they come in the room, I want everybody to fill out this form, I want, all of the things can be put in place to make somebody feel as comfortable as they can. It also, if any of you have been to the doctor, you know that, for instance, with Atrium, doctors are expected to see a patient every 7 minutes. So for a doctor to see someone every 7 minutes, they don't have the time to have those really long in-depth conversations with people at the end of life to help them feel comfortable in that. The hospice team can do that. They can sit with people, they can work through prognosis, they can help them make decisions about treatments if they're still getting some kind of palliative treatment that's best for them. They can help them decide that if they have a diagnosis that there is an aggressive treatment, that maybe you want to go off hospice and get another aggressive treatment and see if that works and come back to us if it's not successful. That's the kind of time that this team can give. You get a social worker, a nurse case manager, which is an RN, a chaplain, if you so wish, a home health aide. No matter where you are. So we will send a home health aide to a nursing home to help, to someone's home. We've taken care of people under bridges. We've taken care of people wherever they are. And there's also a very strong volunteer service that we have. One of our volunteers, well, she's not really our volunteer, but we just had a grief camp a few weeks ago, and the bunnies came to our grief camp for the children. So we have all different types of things that we have in place to help people. We do have pet therapy. We have some dogs registered with us. We have people who will come cut somebody's hair, somebody who will just come sit, somebody who will do grocery shopping. We have a lot of veterans, which honestly is beautiful, because a lot of the men who are in our service are veterans, and so having somebody who can sit with them and reminisce is a wonderful opportunity. As with probably in this church too, we're still bouncing back from the COVID era when we couldn't allow our volunteers to go out, but we usually have about, so we serve 36 counties. We usually have on staff at least between 800 and 900 volunteers, so we have a lot of people who work with us. That's another option to get. All of our physicians work for us. They aren't doctors who have practices and work somewhere else. They are our employees, so they work for us full time. So there's a doctor associated. We have nurse practitioners. We have a pharmacist on staff that helps with getting medications cleared through Medicare for payment if it's an expensive medication. For instance, people who have Parkinson's have very expensive medication that they take, and without that medication, some of their symptomology becomes unmanageable, and so getting Medicare to agree to continue to pay for a medication when somebody is on hospice but has Parkinson's is something that our pharmacist will do. He checks to make sure that all the medication that people are on are appropriate. Years ago, the #1 hospice diagnosis was everybody can guess cancer. That was what people thought of when they thought of hospice. It is actually not our #1 diagnosis anymore, it's dementia. And followed closely, not even by cancer, by congestive heart failure. So cancer patients are more and more seeking treatment much and much later, because we've made so much improvement in treatment of cancer that people choose to stay on pretty aggressive treatment for a long time. The length of stay of our cancer patients is much shorter, unless it's somebody who personally makes the decision that they no longer want to have treatment and make that choice for themselves. But from a doctor's referral, they come much later. The way that we are managing people, particularly with things like Parkinson's with the expensive medication and dementia, I don't know how many of you know, but they have shown an inverse relationship between Alzheimer's disease and a lot of other disease processes that strike the elderly. Alzheimer's patients live forever. They live a long, long life, and from diagnosis to death is usually around 15 years, and probably the disease has been in place at least 10 years before diagnosis, so it's a very long process. So Medicare has gotten very strict about who is appropriate for treatment and the hospice benefit when they have Alzheimer's disease. But I will tell you that there are often things that go along with having Alzheimer's disease that can also qualify somebody for hospice, because a lot of people, if you know some, you know that they begin to have failure to thrive. They're not eating well, they're losing weight, they're having other difficulties, and so there's ways that we can get them onto service to care for them. It is an exhausting job for the family, and a lot of times when the hospice team comes in, you see actually an improvement in the patient, because they're getting things like our pharmacist, which is how this started, getting them off medication they don't need anymore. I don't know if any of you have ever tried to get something taken off your medical record. It's very hard. Usually you have to have a diagnosis taken off by the doctor who put the diagnosis on. So first you have to figure out who put a diagnosis on you before you can get it taken off. You can't just go to your general practitioner and ask them to remove something. The same happens with medication. It's very unlikely for one doctor to take you off a medication that a different doctor prescribed. So we see a lot of dementia patients who are still on the treatment, like the memory treatment that they had been put on early in the process, and they're still taking it. It's no longer benefiting them, and in fact is causing risk, because those medications are fall risk things and they affect blood pressure and all that stuff. So our pharmacists will go through and take them off that. That's the good part about having a pharmacist on staff. The other thing that we have besides the social worker, the nurse, the home health aide, the volunteers, the chaplain, the pharmacists, the doctors, the nurse practitioners, is that we have a very large in-office team that supports us and allows our nurses and our staff, that is our clinical staff, to do nothing but clinical work. They aren't expected to do any of their own follow-up past documentation. That's all handled by the back office. And we have in our company an after-hours team that only works at night. So our nurses go off the clock at 5 o'clock when they're done. You go onto an answering service, and if there's a need, because everything awful happens at night, it seems, particularly with our patients who have breathing issues. We have nurses that are awake overnight to come out. And that is very different than a lot of our competitors who are for profit, because that costs money. Everyone gets exactly the same per day rate to care for a hospice patient. Every company in the United States from Medicare gets the exact same amount. How you choose to spend that money is up to you. We are probably a $45 million company. At the end of last year, we had $20,000 left. We spend everything. That's the idea of being a nonprofit, is you're spending everything to put the most you can back into your patients, which means we pay for more equipment, more supplies, more medications than somebody else might. And I'm not saying that the staff working for any other hospice doesn't care just as much as we do. It's just we have less hoops to jump through to get the patient the thing that they need. And any of us can walk into our CEO's office and say something versus, I worked for Atrium for a while. Hospice to Atrium's president to walk in is, he's in Wisconsin, he's not even here anymore. So the ability to have that kind of conversation isn't there, which is why I feel really good about coming out and presenting Health Partners, our VIA Health Partners, because I've worked it and I've worked in the field for so long, and I tried for a few months to sell a different product and I was not impressed. You have to believe in what you're selling, because we're just trying to get families to trust us. We don't really have anything to offer. We don't have a product per se, so much as trust us to take care of your loved one and to take care of you. Okay, palliative. You will hear doctors tell you that palliative is pre-hospice, and it makes my skin crawl every time they say that, because it's not true. It's two totally different programs. When you hear the word palliative, it actually means any comfort care. So hospice actually falls under the umbrella of palliative care, but for us, it is two different products. Palliative being caring for someone with a chronic illness who probably has 3 to 5 years with their chronic illness before they become eligible for a hospice diagnosis. So somebody who is getting dialysis, and maybe the dialysis isn't as effective as it used to be, because as you go through years and years of dialysis treatment, eventually it gets to the point where your body doesn't tolerate it very well. We can have a palliative team working with that family. Dementia, almost every dementia patient could have a palliative nurse following them. Because again, if you have a urologist and a neurologist and a general practitioner and maybe a heart doctor, cardiologist, and perhaps you have some issues with orthopedics, so then you have 7 doctors and nobody's talking to each other. And what the palliative team can do is bring all that together under one umbrella, look at everything, look at all the documentation, pull all the records, look at medication, have conversations with the pharmacist, and make sure that the person is getting the best care they can get for where they are in their disease process. And also, going back to the 7 minutes that the doctor has, the palliative team have the ability to sit with people and help them make decisions about what the best course of action is for their particular disease process to help them. For example, LCI, Levine Cancer Institute, has their own palliative program. The only people who are referred to their palliative program are people who are diagnosed at stage 4. So if you go to the doctor tomorrow and find out you have stage 4 lung cancer, you will get a palliative order, because there is so much for you to kind of ingest and make decisions about, and big medical decisions to make, so they help those people do that, but they don't have the bandwidth to offer that to everybody who is in LCI. So they often refer to us. when it's somebody that they think could benefit from having somebody overlooking their whole thing. Now, palliative can also be a one and done. I'm to the point, say, a person is thinking, I'm to the point where I should really have stuff in order. I need to make sure I have my advanced care plan. I want to make sure that I have a living will. Those are the things I need to have a talk with my family about what it is that I want at the end of my life. A palliative team can come out in and help do all that paperwork. Make sure that somebody fully understands what they're signing, what decisions they're making, why they're making those decisions, and to help them have the vocabulary to have that conversation with their families. One of the facilities in town is doing a program called Don't Leave a Mess, and one of the things that they talked about is having a plan in place and making sure that people know what it is. How many people have done advanced care planning? Anybody? Okay, good. So 3 things. A living will is just a suggestion. The doctor doesn't have to do anything that's in your living will. It is telling him what you would like, but doctors have the ability to make whatever decision they feel most medically appropriate in the moment. So in a way that's really good, because I also have a living will, but if I was in a car accident on the way home, I hope that they would do everything for me that they could, because I'm perfectly healthy right now, so please do everything you can to save me. Versus if I'm in an operation and you cause apraxia and I'm not gonna have brain activity, then there's a different choice that I would want to make. So the living will is a suggestion. Your healthcare power of attorney. How many people have a healthcare power of attorney? I hope you put a lot of thought into it. Shouldn't just be your oldest child. Most people, I think, start with spouse and then make choices after that. It needs to be somebody who's going to do what you want. If you do not want to live a certain way, you need to be sure that the person that you assign is going to follow your wishes. One thing that we see is the exponential growth of family dynamics at the end of somebody's life. All the stuff that's been brewing for all those years comes right to the surface. And we can't get 5 people to decide where to go eat dinner, let alone what's gonna happen to mama when something's happening to her health-wise. So it's very, very important to make sure that you are picking a person that you feel confident is going to carry out your wishes. So that's another thing palliative can do. The other thing palliative can do is help people determine when's the right time to go to hospice, because I think that's the hardest thing. We never hear somebody say, I wish I had gone to hospice later, but we hear a lot of people say, we wish we had made that decision earlier. And so having a palliative team in helps that family kind of get to that point faster. Only about 50% of our palliative patients ever become our hospice patients. A lot of our patients just either improve or don't ever need hospice or have a sudden death that they don't come onto the hospice program. So about 50%. But they operate completely separate. It's a completely different team. Palliative is covered by Medicare like anything else under Medicare Part B. So it's 80% covered by Medicare, 20% either out of pocket or co-insurance. Whereas hospice is billed under Med A. So the 2 things billed under Med A are hospitalization and hospice. Okay, so you can be on hospice and still have your regular doctor and still go see your regular doctor. A lot of people think that when they come on hospice, they can no longer see their doctor. That's not true. Probably in a lot of cases, some of the doctors become irrelevant, like things like the eye doctor people will choose not to go to anymore. A cardiologist may say, you don't need to come see me anymore because the hospice is updating me, and if there's something urgent, I'll work with the hospice doctor. And it does make it easier for people at the end of their life not to have to go out to so many doctors. Insurance, most of our people who are still on private insurance has some kind of a hospice benefit. It's probably not 100% because nothing is 100% under the insurance that we're paying for. But you can look and see what's available. Also, there is the ability to determine permanent disability and get you on Medicare if you're under the age while you're in the hospice program. Okay. Other thing I left. Oh wait, one more that I want to do too. One of the other myths is that we won't treat anything. In other words, I get a cold. That cold turns into pneumonia. I'm on hospice, you're not gonna give me antibiotics. That is not true. We are not trying to hasten anyone's death. We're gonna treat infections, things like UTIs, upper respiratory infections. If the person has breakdown and they get an infection in their wound, we're gonna care for the wound and give the appropriate medication for that. All of those things are covered and will be treated and cared for by your hospice nurse, so again, you don't have to go to another doctor to have that treatment. Again, this is not doctor-assisted suicide. This is hospice, just walking with that person. We're not trying to speed anything up, okay? There are times that people choose to let an infection go without being treated, particularly with dementia patients at the end of life. It's a choice that a family can make to not treat a UTI, and eventually that person will become septic, and we will manage the symptoms of being septic and help them die pain-free. There's no reason that anybody in the healthcare system we have today should die in pain if they choose not to. And part of what we do is that. There are lots of medical things like nursing homes, assisted living, family care homes. They specialize in residential treatment. The reason why we come in on top of that residential treatment is because we specialize in end of life, and it's completely different. Being able to prescribe medication quickly, have our doctors on call so our nurses can get answers very quickly for rapidly changing medication is a great asset to have. Morphine, in fact, can be increased every 2 to 3 days. We build up a tolerance to it. And as I said, there's no top dosage of morphine, so we just keep building and building to keep that person comfortable. Our company has 3 hospice houses. I have a flyer back there as well, in the greater Mecklenburg area. One at Southminster campus, one at Aldersgate campus, and one freestanding in Huntersville. You don't have to live at Southminster or Aldersgate to go there. We just lease property on their campuses. Our hospice houses are used not for residential care, but for short-term care to help manage symptomology, keep people out of the hospital, because most hospice patients say very clearly that they don't want to go back to the hospital. So the things that we can do at our hospice house is care for somebody who has very high oxygen levels, someone who has uncontrolled pain. So if we were giving somebody morphine every 15 minutes, we would bring them to the hospice house and find a different solution because it's obviously not working for them. We would want to find a longer solution for pain management. So we would put them in our hospice house. They may stay there 5, 6, 7 days while we figure out the medication and send them back home. We always want people to be in their home where they're most comfortable. We do have end of life or death stays at the hospice house. Usually those are either our younger cancer patients who have children in the home and they determine that they don't want the person to die in the home, or people who get terminal agitation, which is, if any of you have seen it, it's very uncomfortable to watch. It's people who are trying to crawl out of bed, constantly moving, pulling off oxygen, and it is a brain chemistry reaction to the fact that the person probably isn't absorbing oxygen as well anymore, and as the body is shutting down, the body's starting to panic. And if any of you have had a situation where you were anaphylactic and you felt like you couldn't breathe, the one thing you really want, you're panicked. There's nothing that you can do about it except for be panicked. So a lot of people will come to the hospice house for that. Also, we will take people direct admissions out of the hospital. If somebody shows up at the hospital and they are actively dying, the hospitals will send them to us because the emergency room is not the place to die if you don't have to. Our hospice houses are quiet. We only have 8 to 12 people in each of them with an abundance of staff. And so it's just a different experience. It's beautiful. We have rooms for our families. They never have to leave. There's no visiting hours. There's washing machines for families and food brought in. So it's just a nice environment. Most of that, again, is paid 100% by Medicare when it is an appropriate placement. Some people will choose to stay with us and pay privately once they are no longer at that hospital level of care, but we try not to do that because we want to have it available for our people who are at home to make sure that they can be managed and comfortable. Okay. The other thing I left, and I only have a few more minutes and I want to give you time to ask questions if you have any. I left 2 flyers, one that tells you when somebody is palliative appropriate and one to give you some idea of when somebody's hospice appropriate. So if you have a loved one, family member, neighbor who's been in the hospital 3 times in the last year, that's an appropriate palliative referral. And the hospitals now, another change is that Medicare has made is if somebody goes to the hospital for congestive heart failure, and they're in the hospital 4 days, and the hospital sends them home, and within 30 days of that, they appear at the hospital again for congestive heart failure, the hospital will not be paid for the first inpatient stay. Because in Medicare's eyes, you didn't cure them, we're not gonna pay you. So the hospitals are sending out palliative referrals for these people who have been in the hospital multiple times to try and help manage that while they're in the home. So if we have programs that, for things like congestive heart failure and COPD, where our on-call staff is trained to know that someone is on those programs, and when they call in, they go through the medications, they make sure the medication was given appropriately. They're doing everything they can to keep that person out of the hospital and to manage it safely at home. When it's a hospice patient, we will send a nurse out. When it's a palliative patient, we will triage it over the phone. We don't send a nurse out in the middle of the night to a palliative patient. But those are back there if you want to look at them. And the palliative one, it talks a lot about the different diseases, heart disease, liver disease, all those things can make somebody eligible for palliative. And you don't need a doctor's order. You can just pick up the phone and say, I'm calling for Susie Smith. I'd like to make a palliative referral. We'll contact the family and make the appointment and go out. Usually takes about 2 weeks for that. A hospice admission will be done within 48 hours and can be done same day or same hour if need be. The other thing I left was our camp. So they were at our one-day camp, which was at Hemby a couple weeks ago, but we also had a 2-day grief camp for children between the ages of 7 and 17. It's in October, and it's at Camp Thunderbird. And we had 35 kids registered for our day camp a few weeks ago. Last year we had 4. So the expectation is that fall is going to be packed. And we do not charge for this camp, and they don't have to have been, a family member doesn't have to have been in our hospice services to be eligible. So I tell you for 2 reasons. If your church is looking for something wonderful to donate to, you can send a camper to camp for $500 and sponsor that camper. But also, I want you to know this, so if you have people in your life, children, who might benefit from this, it's on our website, and honestly, a lot of our referrals come through the school system. But if you know somebody in church, it could be a grandparent, a friend, somebody who was affected by the stuff that went on in the Greek school a few weeks ago where a child passed away. It could be somebody who lost somebody during COVID and didn't get the ability to go to the funeral and grieve the way we all traditionally know to grieve, but that wasn't happening. Kids can come once, they can come every year. Kids grieve at every stage of development, so it's appropriate for kids to come back through all their cognitive changes. And we actually have kids who started at camp and are now counselors. So it's our 25th year of doing this, and it's great for the kids, but I gotta tell you, it's great for the counselors too. It's amazing to watch them kind of get through, and heartbreaking to see how many children have lost their parents, but also how they are being surrounded by other people who have been through the same situation. And so I'm 57, and I just don't remember that much when I was in school of hearing of people's parents passing away that you hear now. And so it's wonderful that we're offering something to kids to give them that support. Okay, we only have 10 minutes before you guys have to skedaddle into church. So does anybody have any questions? Can you think of anything I didn't cover that we talked about?
I thought it was great. And let me just mention questions. We're going to turn off the recording. We'll have recording for those that missed
and
it today.
And I did leave my card in the back, so I understand that not everybody wants to ask questions in a whole big group. So you are free to reach out to me privately if you want. It is my work number on the card, and I do look at it over the weekend. So anytime anybody needs to call me, you can. Okay. Questions? I was that good.
Yeah, that was very good.
Let's see, I'll tell you another story then. We had another heartfelt story. We had a patient up at the lake who was dying with cancer just recently, and he had been a pilot in the Navy, I believe, and he wanted to get up on a plane one more time, And our social worker managed to find somebody with a private plane that took him up in a plane one last time, just a few weeks ago. We had a person who was, this was years ago, obsessed with Star Wars, obsessed. And one of the new movies was coming out, and she really wanted to see that movie. It wasn't really safe for her to be out in big crowds, and we didn't know how long she had, and they made arrangements for her family to have a private screening of the new Star Wars movie at a movie theater. I mean, it's just wonderful things to be able to allow people, again, to live their best life. We're all on a ticking clock, but we walk through our days as people who don't have hospice or terminal diagnosis. We walk through our days thinking that today's not the last day, that we don't do those things. And when you have sped up time and you know that it's coming, the things that people want to get accomplished and the things that people want to do and the things that people need to say to their loved ones or to themselves or to their worst enemy become more and more important. And our team is there to help them do that, and particularly our social workers do a lot of that work to make sure that people have the thing that's most important to them carried out. It's one of the first questions they ask at admission. What are the most important things for you right now? And how can we help you to manage that? I think a lot of people have a bad connotation with social workers, and a lot of people will think, why do I need a social worker? You know, I have my money in order, I have this in order, I have that in order, and it's really the emotional support, and also with the chaplains. A lot of people will have their pastor or their priest or whoever coming to see them at the end of their life, but our chaplains present non-denominationally. They are there really for more spiritual support, because hospice views 5 kinds of pain: physical pain, mental pain, spiritual pain, social pain, and personal pain. So it's the relationship pain, the fact that people are leaving somebody. How can they wrap up those relationships or solve the things they need to do, or all that. The physical pain is obvious. Spiritual pain, you hear about people becoming more spiritual at the end of life or more angry at the end of life, so helping them with that. Social pain, because you're isolated, because people can't come see you, because you can't get out and do the things you used to do. So we're wanting to help all of those 5 types of pain that we've identified of people who are at the end of life. Yes, a question, yeah?
I had a question about palliative care. Who
Yes.
decides, or how is it determined that somebody can benefit from palliative care, or when do you know that?
So part of this is on this list. So some of the things on this list are advanced cancer, end stage, renal disease.
But is it the doctor that determines that? Or
It
the
doesn't have to
family,
be.
or the
So
person?
if you picked up the phone and called in and said, my mother needs palliative care,